Good afternoon, everybody. This afternoon, we are going to lecture on emergency radiology of the chest. This lecture will be quite different from the other lectures as we will be discussing and showing the emergency radiology procedures that are very common in the hospital through case discussion of some cases. Okay? This is a 42-year-old male who had a motorcycle accident, and you can see from your previous lecture on chest radiology, the right lung field is normal. Okay. Then the tracheal tube is deviated towards the right side, and there is a fairly homogeneous density on the right-left lung field. Okay. You cannot see the aortic isthmus as it is blurred by the density. Consider in road traffic accidents, majority of patients die before reaching the emergency room. And most of these patients or most of these injuries are secondary to deceleration injury, meaning to say that the impact of a moving body against an immovable object happens. And these deceleration injuries usually are located in the aorta, which is the usual site of rupture, and the low locations in the aorta, which is the usual site of injury, are the aortic isthmus and the distal part of the aorta, which is beyond the subclavian artery. The clinical features of patients secondary to deceleration injury requires a strong suspicion from the mechanism of action. Thereby, it is very important that the complete history of how the patient had the accident is very important, simply because this will tell you of the possible site of injury of the patient. Chest examination is very important, especially the sign of interscapular pain, which is an indication of a possible aortic rupture. And what is important is the examination of the brachial artery and the lower artery pressures. The differential brachial blood pressure between the right and the left will tell you whether your rupture is before the left subclavian artery, or it is after the left subclavian artery. Because if it is before the left subclavian artery, usually there is difference of pressure or pulse pressure between the right and the left radial pulse. If your trauma or the aortic rupture is after the left subclavian artery, usually there's a difference of the pressure between the upper and lower extremity femoral pulse volumes or pressure. This is a radiographic finding that our patient had when he went to the emergency room. There is a widened mediastinum which is greater than 8 centimeters on a supine AP view. There is a blurred aortic knuckle or with loss of the aortic knuckle secondary to bleeding. And the left apical pleural cap is very important also, that will indicate that you have blood on the left hemithorax. The other thing that is very important here is because of the aortic rupture and the accumulation of blood in the mediastinum, your trachea is deviated towards the right side or the opposite side as indicated here by the shift or the endotracheal tube that is shifted towards the right side. The radiographic features of a ruptured aortic arch secondary to a deceleration trauma usually is left-sided density or hemothorax or fluid. 2. There may be depressed left main stem bronchus secondary to the blood or a raised right main stem bronchus secondary to the mediastinal blood. The trachea or the ET tube is displaced towards the right side. There may be multiple rib fractures, and usually the rib fractures that are available may be the posterior ribs of the chest. There can also be involvement of the anterior chest depending on the site of injury. Usually, if it is anterior chest ribs that are injured, the trauma or the rupture involves the ascending aorta. For rib fractures in the posterior ribs, usually what is involved is the part of the aorta that is posteriorly located. There may be also diaphragmatic changes secondary to the fluid collection in the hemithorax. This is an angiogram of a patient with an aortic rupture, and you can see the aortic rupture is beyond the left subclavian artery. And you can see here, this is the aortic aneurysm, and this is the aortic flap. This is just a diagrammatic picture of what happens in patients with aortic trauma. There can be torsion stress, there can be bending stress, shearing stress. Usually, the blood is not from the aortic rupture or the blood is not from the aortic torsion or bending stress. Usually, the blood comes from the severed or disrupted intercostal artery secondary to the aortic rupture or secondary to the torsion or movement of the aorta because of the deceleration trauma. This is a patient who had an echocardiography secondary to the aortic rupture, and you can see here the transesophageal echocardiogram. You can see here the aortic flap or the intimal flap. Usually it is the intima that breaks, and you can see here this is the intima and there is discontinuity on the opposite side of the intima, and this is the intimal flap. There is the aortic dissection and the portion of the aortic rupture. Usually the tunica media and the adventitia are maintained. So what happens is blood goes into the subintimal layer and is contained by the remaining wall of the aorta. This is a CT scan of a patient with an aortic rupture, and you can see vessel disruption or extraluminal blood seen in contiguity with the aorta, which is indicative of a rupture. And you can see here, there is contrast media of the aorta, there is blood in the subintimal layer. Okay, this one is another one with a patient who had an aortic aneurysm or aortic rupture. There is a false lumen, which is the central density here containing contrast media and blood, and there is a false lumen surrounding that true lumen. This is the dissected wall. Okay. Now, our next patient is a 50-year-old female brought to the emergency room because of wheezing and exertional dyspnea. She is a chronic smoker, has chronic cough. And what you can see here, if you will recall the normal chest X-ray of a patient uh, from your previous chest lectures on the normal chest, what you can see here is the lungs are hyper-aerated. It's very, very black compared to the normal grayish lung in a normal chest X-ray. The cardiac shadow is slendered out, secondary to the pressure of the air. Okay, it is slendering. Not you lose the convexity of the left cardiac border as well as the convexity of the right cardiac border because of the pressure of the hyperaeration and the increased air in the lungs. It is the heart shadow is compressed because of that pressure, so it becomes a slender heart or a sexy heart, as some radiologists will call it. The other thing that you will find here is the convexity of both hemidiaphragms is lost. The diaphragms are flattened out, okay, and sometimes, and in this case also, you can see that the level of the hemidiaphragm is not in its normal location. As we all know, the normal location of the hemidiaphragms is the 10th posterior rib. In this case, it is flattened out, low in position, and usually in this case, it's already below the 11th posterior rib. Okay, so we have signs here also of hyperaeration. The intercostal space are widened. Okay, that is all because of the presence of accumulated air in the lungs. So again, what we have here is a slender heart, hyperaeration, depressed hemidiaphragm, flattened hemidiaphragms, and also increased in the intercostal space. On the lateral projection, what we have here is a widening of the AP diameter of the heart, of the chest, or what we term in radiology as the barrel chest. There is hyperaeration, and if you look at the retrosternal space, normally the retrosternal space should contain the heart, two-thirds of the retrosternal space should contain the shadow of the heart. In this case, it is only one-third of the retrosternal space contains the cardiac shadow, meaning to say, there is a lot of air in the retrosternal space pushing the upper cardiac shadow posteriorly. That is why it is the two-thirds of the retrosternal space contains air. So again, the lateral view shows you the presence of hyperaeration in these patients. In COPD, this is a general term which refers to either chronic bronchitis and emphysema. There is airflow reduction and resistance to expiratory airflow, secondary to infection, mucosal edema, bronchospasm, and bronchoconstriction, reduced lung elasticity. The causative factors include smoking, chronic asthma, alpha-1 antitrypsin deficiency, and chronic infection. The clinical features, usually this is caused or precipitated by a chronic infection. Symptomatology is usually cough, dyspnea or wheezing. There is tachypnea with use of the accessory muscles of respiration, and in severe cases, there may be cyanosis, signs of heart failure, hypercarbia, hoarse tremors, bounding pulse, peripheral vasodilation, drowsiness, and confusion. Radiological findings 1. Chest PA is moderately sensitive but highly specific. It shows the extent of degree of parenchymal lung damage, and it can assess complications like pneumonia, heart failure, lung collapse, atelectasis, and rib fractures. You may also see bullae or blebs in cases of COPD, and sometimes you may see pneumothorax secondary to the rupture of the bullae or bleb cavity in these patients, and which are termed as spontaneous pneumothorax. There is flattening of the hemidiaphragm, as we have all said. The convexity of the hemidiaphragm is lost, and the position of both hemidiaphragms is below or lower than 10th posterior rib. There is hyperexpanded lungs with flattened hemidiaphragms. There is pruning of the vasculature secondary to the pressure of the air, excessive air in the lungs. There is a barrel-shaped chest with the presence of lung bullae or blebs. Next case is a 45-year-old female brought to the ER, had sudden history of chest pain and difficulty of breathing. There is collection of gas in the pleural space as shown by the chest X-ray. If you will look on the right side, you can see here the visceral pleural line. The visceral pleura is the pleura that outlines or is very in close contiguity with the lung parenchyma. The parietal pleura is that pleura which is in contiguity or attached to the chest wall. So that the pleural space between the visceral pleura and the parietal pleura is usually a dead space. So in cases of pneumothorax, what happens is the air collects between the parietal pleura and the visceral pleura, and because of this, the visceral pleura moves away from the parietal pleura as it is attached to the lung. So there is an air space or air in the pleural space. And if you will note, since the lung has moved away from the chest wall, that air does not contain any interstitial or lung markings. So it is usually defined or described by radiologists as an area of lucency devoid of lung markings. That is indicative of a pneumothorax. Okay? There is increase of intrapleural pressure secondary to the air. There is overexpansion of the hemithorax and varying degrees of lung collapse depending on the extent of the pneumothorax. The etiology or the definitions or classifications is 1, spontaneous pneumothorax, primary, secondary to ruptured pleural bleb or bullae, secondary, second, which is due to COPD or tuberculosis. Another category of pneumothorax is traumatic pneumothorax. It might be non-iatrogenic, but usually in 90% of cases, the traumatic pneumothorax are iatrogenic secondary to passive pressure ventilation, central venous catheterization, endotracheal intubation, or sometimes injury to the lung itself, like gunshot wound and stab wound. Now, the signs and symptoms, there is sudden onset of chest pain and dyspnea, ipsilateral expansion of the chest wall, decreased tremiti, hyperresonance because of the accumulation of excessive air, and decreased breath sounds. There may be contralateral tracheal shift or even mediastinal shift in cases of tension pneumothorax. There is, in severe cases, sometimes there may be cyanosis and hypotension. Radiology, plain chest X-ray is usually the first modality of choice in cases of pneumothorax. It can be done in inspiratory or expiratory film. Usually, in a chest X-ray of patient with pneumothorax, it is usually taken in an inspiratory uh, phase. But in some cases whereby pneumothorax is highly suspected and is not seen on an inspiratory film, usually an expiratory film is requested. This is in cases of pneumothorax because in expiratory film, the chest pressure decreases so that the pneumothorax will show itself if it is not seen on the inspiratory view. The visceral pleural line is noted, as in this case, we can see the visceral pleural line secondary to the accumulation of air in the right lower lobe. There can be varying degrees of atelectasis or mediastinal shift depending on the amount of pneumothorax, whether it is massive or tension pneumothorax. Chest CT scan is usually more sensitive than chest X-ray because it can detect small amounts of pneumothorax, and also a chest CT scan can detect loculated pneumothoraces. Our next case is a 63-year-old male, a smoker. He had a lung mass on chest X-ray, a left hilar mass. No intervention, was lost to follow-up. Suddenly, he went to the emergency room, complaints of shortness of breath. Okay? Chest X-ray requested to assess the patient's present condition. This is the chest X-ray of a patient. You can see that there is homogeneous density on the left lung field. Aside from that, you can see that the trachea is deviated towards the side of the pathology, which is the left side. The heart is also deviated towards the left side, and there is compensatory hyperelevation of the right lung field. In cases of unilateral or pacified lung, there are three things that you will have to think of. Your differentials will be one, massive pleural effusion, two, massive pneumonia or consolidation of the entire lung, and three, atelectasis of a lobe or the entire lung. In massive pleural effusion, it is fluid that accumulates in the surrounding spaces of the lungs or extrapleural in location. The excessive amounts of fluid impairs breathing by limiting the expansion of the lungs, since it is in the extrapleural space. During inspiration, because of the diminished expansibility of the lungs, there is shortness of breath. Here in this chest X-ray, we see two pathognomonic and very typical signs of pleural effusion. One is the meniscus sign. The meniscus sign is brought about by the increased surface tension of the lungs over the accumulated fluid. That is why it is a cup-shaped or concave deformity. The other one is also because of the surface tension, the lateral side of the fluid is pushed laterally and upwards, which is now known as the Damascus curve. So in this chest X-ray, we have two pathognomonic signs of pleural effusion. This is a massive pleural effusion. As you will note, there is a homogeneous density on the left lung field pushing the tracheal air column and the mediastinal structures towards the opposite side. This is typical of pleural effusion because of the pressure of the fluid. It pushes the mediastinal structures, the heart, towards the opposite side. This is just a case of a bilateral pleural effusion, supine position. You do not see the meniscus sign, and you can see that you do not see the Damascus curve because the fluid moves at the back of the patient, and you can see here a veil-like density on both lung fields. In the erect position, that is where you see the meniscus sign and the Damascus curve, okay, because the fluid is collected at the bases of both lung fields. Chest radiograph, that is the primary diagnostic tool. 200 ml of causes blunting of the lateral CP recesses in an upright TA projection. Okay, you do not see the blunting of the cosophrenic sinuses in cases of the supine position because the fluid distributes at the back of the patient. 50 ml causes blunting of the posterior gutter in the lateral view, and 5 ml causes is positive on the lateral chest decubitus as a ribbon-like density. Pleural effusion, the magnetic signs are usually meniscus sign and the Damascus curve. Homogeneous opacification of the hemithorax or diffuse haziness with ground glass pattern, especially this one. The homogeneous opacification in an upright projection. The diffuse haziness or the veil-like density with ground glass pattern usually is in the supine position. The visibility of the pulmonary vessels may be seen through the haziness. There is absence of air bronchogram simply because the fluid collection is outside of the lung parenchyma. Chest lateral view here, you can see here the posterior gutter blunting here. You do not see the sharpness of the posterior gutter, and also in the right lateral decubitus view, you can see that ribbon-like density, which even just 5 ml will be enough to manifest it as positive. Chest ultrasound sometimes is being done, and you can see it detects as little as 5 to 50 ml of pleural fluid. It is very nice to do ultrasound because it identifies the loculated fluid collections. It detects pleural or chest wall-based tumors also. And you can see here, the effusion is hypoechoic, and this one is the collapsed lung. You can see here, and sometimes the beauty about ultrasound is that you can measure the approximate amount of pleural fluid in a chest ultrasound as compared to a chest X-ray. Okay. Now this is another ultrasound. The fluid, there is fluid here. There is the collapsed lung. In this case, this is the hemidiaphragm. Okay, this is the effusion. This is the spleen. But you can see here band-like density, which is a fissure. Okay, a fissure of the lungs that is seen on a chest ultrasound. Chest CT scan, you can see here the hypodensity that collects posterior since the patient is in the supine position. The hypodensity here is the one that, that is the fluid on both lung fields. This is just the shadow of the tip or the dome of the right hemidiaphragm. And this one, the density here that you can see is part of an atelectatic lung secondary to the effusion. Now, another differential that you have to think of in a density, in the homogeneous density or veil density of the left lung of one lung field is pneumonia or pneumonic consolidation. You can see here in pneumonic consolidation, the mediastinal structures are maintained midline. The heart shadow is also midline. It is in its normal position, but you already can see here density. The other thing here is that through the density, you may see lucencies, which are air contained in the normal bronchioles of the lungs. Because usually in pneumonia, your infiltrates are in the alveoli, but the bronchial trees usually, unless it is extensive, usually they will not contain pneumonic infiltrates. So you can see a normal air bronchogram, which means air in the normal bronchus. This is very good to see since because air bronchogram will tell you that most probably what you have in this patient is an inflammatory process and not a malignancy. Because in the malignancy, usually the bronchioles are destroyed by the malignancy. So you will not have an air bronchogram. Okay, here, okay, this is a patient with the right mid-lung density. Okay, the thing here is that you do not see the right cardiac border and you do not see the medial margin of the consolidation. This is what is termed as a silhouette sign, and usually this is indicative of a pneumonic consolidation involving the right middle lobe there on the lateral projection. Okay, there is effacement of the right cardiac border, and on lateral projection, the middle lobe is seen between the horizontal and the oblique fissures. Now, the silhouette sign indicates that two structures or two densities are usually on the same plane because one density obliterates the outline of the other density. That is a positive silhouette sign. So it is only seen if two densities are on the same plane. If this density here shows you the right cardiac border, most probably that density is not in the right middle lobe because it is the only structure or the only lobe that is in the same plane as the cardiac shadow. If there is a density or there is the shadow of the right cardiac border here, if you have a density here, most probably the density is in the right lower lobe. Atelectasis, the other differential is atelectasis or collapse of the entire lobe. When the airways to the lungs are blocked, tiny air sacs called alveoli are unable to fill with air and perform their functions of exchanging oxygen and carbon dioxide. The result is atelectasis or collapse of the lung tissue. This is atelectasis. You can see here. You can see homogeneous density on the right. The tracheal air column is deviated towards the side of the injury or ipsilateral, and even the cardiac shadow is deviated towards the side of the pathology. And you can see here that there is hyperaeration of the left lung field. This is the chest X-ray of a patient. There is loss of volume of the affected left lung. There is shift of the heart and the tracheal diaphragm towards the side of the volume loss. There is narrowed intercostal space, as you can see here, compared to the right side. The intercostal spaces are narrowed. There is overinflation of the opposite lung, which is termed as compensatory hyperaeration, while with widened interspaces. If atelectasis is on the left gastric air bubble, as you can see it here, the gastric air bubble is displaced upward because the hemidiaphragm also moves upward secondary to the atelectasis on the left side. So in our patient, our clinical impression is left hilar mass with obstruction of the left main bronchus, lung tissue collapse, producing atelectasis of the entire left lobe. CT indication, chest radiographs generally sufficient to diagnose lobar atelectasis and to identify the collapsed lobe. In some situations, chest radiograph findings may not be diagnostic. This generally occurs when pleural fluid or large pulmonary masses are present. CT scan is a useful imaging study. You can see here, right lung filled with atelectasis secondary to massive pleural effusion on the right side. We have a 58-year-old male, anterior chest wall pain radiating to the back, history of uncontrolled and chronic high blood pressure. What you can see here is that the cardiac shadow, of course, appears to be enlarged. There is dilatation of the aortic arch as well as the descending thoracic aorta. Okay, so most probably what we have here is a patient with an aortic aneurysm. So this is a normal radiograph. On the lateral projection, you can see the retrosternal space, the right pulmonary artery, the right ventricle, the left ventricle, the IVC going up, the left atrium, the pulmonary artery, and the aortic arch. Compared to the lateral view of that patient, you can see here a a density secondary to a markedly dilated aorta, ascending aorta, and aortic arch, and up to the proximal portion of the descending aorta. So this is your aortic aneurysm. By the standard classification, type A usually involves the ascending aorta, aortic arch, and going down to the thoracic aorta. Type B usually involves only the part of the aorta after the left subclavian artery. In our patient, what is dilated is from the aortic arch and ascending aorta and descending aorta. So most probably our patient has a type A by Stanford classification. In a CT scan, the dilated aorta is usually more than 4 centimeters in diameter. Contrast-enhanced blood in its lumen with calcification in its wall, and usually it is very important in subsequent CT scans to monitor the increase of the diameter of the aortic dilatation. You can see here the normal lumen containing the contrast media, and this is part of the dilated aorta, but this is also a thrombus secondary to the dissection or the aortic aneurysm. This is a type A classification, the Stanford classification. You can see the aortic arch is dilated. The ascending aorta is dilated, the aortic arch also, and part of the descending aorta. This is a Stanford type A. And the chest CT scan of the patient, you can see here the lumen, which is also dilated, and also the part of the dissection which has or contains the thrombus of the dissected aortic aneurysm. This is just a saccular aneurysm of the aortic arch here, and you can see here the left subclavian artery, and you can see here the brachiocephalic artery and also the vertebral artery coming out. Okay. This is the normal aortic arch, ascending aorta, aortic arch, descending aorta. Okay. A is the right brachiocephalic artery, B is the common carotid artery, and C is the subclavian artery, and you can see here the vertebral arteries. This is a type 2 Stanford B classification of aortic arch. You have a dilatation of 7.8 centimeters, which is definitely very, very dilated beyond the left subclavian artery, and you can see the dilatation as it goes down. Okay. For any questions, message me through Blackboard. Thank you very much.